Thank you. Thank you for having me here. Matt Martin, Rob Lim, Ahmad Huck, Gordy, thank you all for bringing me on to the meeting. I'd like to commend you on a great scientific session. The residents and the quality of the science and the presentations from today was really remarkable. So this is going to be a talk that's directed at redeployment. And you just heard a lot about skills decay and burnt readiness and 0.8 cases over deployment. So I think there's an opportunity here to mitigate the risk of skills decay, provide educational opportunities, and I think that initiative starts with performance assessment. No conflicts of interest, other than the fact that, as he mentioned, I'm a urologist. So over the past 20 years, we've seen a rapid evolution of minimally invasive surgery. The procedures have become progressively more complex. The platform is complex. And the burden, although this is translated into improved patient outcomes, there's been a burden placed on the surgeon as they're responsible for the technical ability to perform these types of complex procedures. There's no sign of this slowing down. We continue to see exponential growth of minimally invasive surgery. This is the FDA-approved procedures for the robot in 2008. This is the current. It just continues to grow exponentially. But I think that the adoption of minimally invasive surgery and robotic surgery has outpaced our ability to educate using the robotic platform, to educate surgeons for robotic surgery and other types of minimally invasive surgery. So the MIS revolution is here. I don't think the revolution in training is here yet, and we need this. With today's emphasis on patient safety, we have to be able to mitigate risk, time, and cost. So you heard earlier reference by Major Brockmeyer to Anders Ericsson, and he's a sports psychologist, and he's a PhD in sports psychology from Florida State University. And I believe there's a lot of opportunity to use the robust science in sports psychology and other high performance, high stakes types of fields to leverage our educational methods and innovations in surgery. But what he talked about was and I would recommend read if you haven't seen this book, it's outstanding. He talks about deliberate practice. Basically, what they have established as the best way to make improvements in the science of expertise is to break the skill down into components that you can repeatedly analyze effectively, determine your weaknesses. So it's not about 10,000 hours. It's about figuring out in a very specific way where your gaps are and how to improve them. Otherwise said more generally, by a local, separation is in the preparation. But you can't prepare unless you know what you're looking to improve. This is Peter Drucker, a famous theorist in economy. He says you cannot improve what you cannot measure. So how do we measure surgical skill? We say things like that surgeon has skills appropriate for their level, they have good hands. You heard earlier in Dr. Hetz's presentation about procedure logs, and we know the flaws in these approaches. You can observe surgeons. Back to how the American Board of Surgery used to initially certify surgeons, and they'd travel to the individual site and watch the surgeon operate. But this is time-consuming, expensive, scalability is a problem. But we may have an opportunity to assess surgeon performance using kinematic data and video review. So This is a landmark paper that you may well be familiar with from John Berkmeyer and the Michigan group, where he looked at he took videotaped reviews of surgeons performing bariatric cases with a validated instrument. I think he used OSATs, followed up the patients for a long period of time, and was able to show a direct correlation with quantified surgeon skill with laparoscopy with patient outcomes. Correlations with operative times, which I'm less interested in times than errors, but he showed correlations with complications, readmissions, and even patient mortality. So we know that the robot actually tracks the three-dimensional location of the instrumentation over time. It records this using the advanced programming interface, the API, and even though you can't routinely access this information, you can using a product that Intuitive makes called the DV Logger. So it turns out that when you look at an instrument's location over time for the same exercise, experienced surgeons will have very minimal path links, very minimal extraneous motion compared to novice surgeons. So this was done using the API. You have an experienced surgeon on the left making 3 throws, suturing throws, 1, 2, 3, 4, and the novice. And you can see how much extraneous motion there is as the novice completes the same exercise. This can also be done in the operating room. This was a study that Andrew Hung did at USC, where he had the DV Logger on the robot and was recording the three-dimensional location of the instruments and the camera during a vesicourethral anastomosis. And you can see the same type of Cartesian plots and the differences in the expert surgeon, the experienced surgeon on the left versus the novice with all the extraneous motions on the right. So the problem with this, though, it's very limited access. We've been doing robotic simulation research at Madigan for 10 years, and we got our hands on the DV Logger 6 months ago for the first time. So it's very hard to get access to this from Intuitive. So what other options do you have? You can look at training data from the simulator, or you can monitor the instruments in the dry lab. Here's the types of metrics that you can get from the simulators. You've probably seen this before. They'll give you the economy of motions with longitudinal tracking of trainees and surgeons' performances over time, instrument collisions, and other metrics. But you can also, if there's deconstructed tasks that you want to perform, and if you want to physically perform, say for instance, a suturing exercise or something that doesn't perform well in a virtual reality environment, then you might be challenged to try to use other means to track these instrument locations over time. So one thing we did was put these visual tracking tapes from the PROMIS simulator, docked it to the robot, and we were able to look at differences in economy of motion for experienced surgeons versus novice surgeons for a variety of different tasks. The problem with the PROMIS is it has a small working area, and it turns out a lot of what's informative for experienced surgeons versus novice on the robot is what the left foot's doing, what the camera's doing, what the clutch is doing. So you need a bigger work environment to start to test the performances of these surgeons. So the next step we went to was using these tooltip trackers, which are electromagnetic transponders that would then pass the information from the tooltip. You could see the retrofitted Da Vinci arms here, passing the data to through the air through electromagnetic transponder that then communicates to the software package. But then you can generate these same types of three-dimensional Cartesian graphs as what you were seeing from Intuitive's API. So experienced surgeon performing a ring tower transfer exercise on the left, novice surgeon on the right. I won't tell you who it is. He's not in this room. But fact is, you can tell then very easily, visually, what the difference in skill level is based on these extraneous motions. Your other way to do skills assessment, another way to do skills assessments through proctored sessions. We're all familiar with FLS, which thankfully, in large part due to SAGES, exists as a curriculum and a high-stakes testing environment. And also, as you all know, it's a requirement for board certification now. The problem with these tests is they're expensive to run. frequently limited in availability, and I think the feasibility of replicating these tasks on a regular basis becomes a challenge. We have something similar in urology. We went out and used the FLS to create the basics of laparoscopic urologic surgery that had a curriculum that was specific to urology with lap nephrectomy and some other, and then added in a arterial clipping exercise, which seemed relevant for us. That's being offered at the American Urologic Association's Foundations course coming up. But in that curriculum, we used the Simulab Edge simulator, which you may have seen before, which actually tracks the three-dimensional location of the instruments over time, the same way as what you would see with the other types of simulators, like the Promus, where then you can generate these Cartesian graphs. Here's an experienced surgeon doing the ring tower transfer versus the novice surgeon doing the ring tower transfer with a lot of extraneous motion, which can then be quantified into economy of motion and path lengths. The other thing the Edge does for you is it turns out that experienced surgeons will grasp something with the laparoscopic instrument with the minimum amount of force necessary in order to keep from dropping it. So the Edge simulator is actually able to track the haptic forces delivered to the instruments through the course of a fixed exercise. And here you can see the differences between the expert and the novice surgeon. Another way to go about this is with graded video review. And that's very similar to what you saw in the Mittmeyer study, looking at the performance of laparoscopic cases. We have the same sort of thing for robotic cases. This was developed with Alvin Go and Brian Duncan down at Methodist. This is an instrument called Gears, which is Likert scaling in multiple domains for video review of the robotic cases. The only problem with this is it's time consuming, it requires expert review, and it's a challenge to get these turned around in an objective, unbiased, and rapid fashion. So one way around this is a pretty novel approach which has been developed by a colleague of mine up at University of Washington, a guy named Tom Linvey. He read a book called The Wisdom of Crowds by James Surowiecki. I don't know if you've seen this book, but it's pretty fascinating. So what he describes is a collective wisdom amongst crowds that can exceed the individual knowledge base or performance of an individual and can be compared to the knowledge base or experience of an expert. He gives the examples of like a town fair where there was a guess the weight of the cow competition, and nobody got within 50 pounds. But when they averaged the 600 tickets amongst all the people there, the average weight came within a half pound of the actual weight of the cow. So what Tom has done is leverage that science to do crowdsourced video reviews in order to return video assessments back to surgeons. So basically what happens is a surgeon submits a recorded video, which goes to a private secure website, goes out to the crowds, which then fill out the Likert scale assessment using the Gears instrument as you saw before. The crowds come from all over the planet, and they typically will return a very quick score for the surgeons that's then they can use to leverage their assessment towards skills improvement. What they've found is that with 30 to 50 crowd members, they can equilibrate to what 3 to 5 expert reviewers do for the same video assessment. So as we move forward, we need to figure out how to incorporate these assessments as skill into training and credentialing. But I also think there's a big opportunity in the redeployment process. As we improve our ability to conduct these assessments, the goal will then be to leverage those assessments to identify the gaps, to provide targeted education and approaches for performance improvement to make surgeons better at areas where we may fall short. So with that, I thank you.